Hi, my name is Kelly. I'm from Pearson Lloyd, and this is my colleague Laura. And we're going to talk to you about our project, A Better A&E, which is a service design project for hospitals in the UK, but also throughout the world. So we are a London-based design and innovation consultancy. We offer design, knowledge, and thinking in various sectors that have demanding spatial, ergonomic, and social needs, such as healthcare, aviation, the public realm, the workplace, product design, and hospitality. We like to explore the relationship between people and the complex environments they inhabit to implement strategic change. And we deliver solutions that combine innovation, pragmatism, and elegance. And our work has received numerous awards and accolades. Since 2007, we've been working in the healthcare sector on various projects, including A Better A&E. So to give you a quick breakdown, what is design? So design is the specification of an object to solve a problem, and it's subject to a set of constraints. Design can be many things. It can be product design, user experience, urban design, fashion. So it works across various sectors, and it is the culmination of a process. But many people only see the end result in the polished product and don't necessarily know all the processes and things that are behind the design. Design can be far more complex than they actually appear, and the process of design is similar for all sectors, although the tools used and the end result can vary greatly. And this process is defined by design thinking. And this is very effective for innovation because it makes problems tangible through direct observation, visualization, and prototypes. And it's particularly useful for service and policy innovation because it renders things that are very intangible and makes them concrete and intelligible to the stakeholders. So by employing design thinking, you invest in a comprehensive process that involves many people. As designers, it's very important for us to understand who the users are and who we're designing for. And to accurately do this, we use tools such as interviews and behavioral observations to capture this information. And we also oftentimes work with ethnographic researchers to do so. We also don't supplant information from other disciplines. If we feel like there's an expert or another field that would really contribute to our designs, we employ these experts to work with us to define the problem and get to a final solution. And as humans, we're constantly preoccupied with systems, and we're subject to them every day in products. And as designers, we really question these systems and these objects and hope to build and improve upon these. But while doing so, we need to take into consideration the stakeholders and their objectives. But by combining these three very distinct interests, we result in user-led and a very innovative result. And this methodology is particularly effective for the relatively new field of service design.
What, in terms of design, what can we say? Well, first of all, it's about curiosity. So it's about what people need and want. It's about understanding your user, your customers. Designers' role is to imagine and dream up a better future, better solutions to problematics. And finally, find ways to do something about it. And there's plenty of ways to get solutions. In terms of service now, well, we can say to experience a service, you need to be there. It happens over time, so through different touch points. And finally, you don't own a service as you own a product, but you're going to use it. So finally, what is service design? Well, service design is about human empathy, understanding the other users, customers. It's a holistic thinking, so keeping in mind the big picture, and it's prototyping the experience. So service design is unique in that it orchestrates great customer experiences across different touch points to deliver value to both users and providers. It can be done on various levels, to commodity to experiences, and they are ultimately encompassed by a better overall experience for both the users and the providers. So at the end, service design creates a mutual value, as I said, to providers, which will end up with a an effective and efficient service, and it will help to be different as well. And for the user, it has to be a useful, usable, and desirable service. So design service leads to better customer experience then. It reduced costs, it increased return on investment, and it leads to great new opportunities for the providers because they get to know better their users. In terms of sectors, service design can be both on public sectors and private sectors, but often it merges, which is actually the case for the A&E project we're going to present you. So you might be wondering what service design looks like, and it could be many things. So we're going to go through several examples. The first one is called No Red Tape. It's a project that has been led for the Danish government, and it's about making the tax more understandable, the tax process more understandable and efficient for young adults. So basically it's about making life easier for the users. The second example is called The Good Kitchen by Hatch and Bloom, and it's about, it's also the public sector, and it's about delivering food for the elderly. Pop-up Park has been led by the Design Council in the UK, and it has been involving young people to create pop-up parks in public spaces. The STBY is improving train platform informations, and this one particularly falls into both private and public sectors because it's working at stations all across the Netherlands, which led me to our A&E project, which is indeed into the public and the private sectors. So just before we present you that project, we need to give you, and we want to give you more information on that project background and context.
In the UK, all healthcare is overseen by the governmental body, the Department of Health. They do not own or directly oversee any of the care facilities, though. That is the responsibility of the National Health Service, or the NHS. So the NHS directly oversees all primary and specialist care, and it's per country. So you have England, Wales, Scotland, and these centers include general practitioners or GPs, hospitals, urgent care centers, etc. But just to make things even more complicated, each of these facilities, they're independently owned and operated, so we cannot mandate that our project gets implemented into every hospital because each hospital has their own stakeholders and their private bodies that then oversee the institution itself. So our project is the result of an innovative partnership between the Department of Health and the Design Council. The Design Council is an independent UK charity that champions great design. And through this partnership, the two organizations wanted to use a design-led approach to tackle existing problems within healthcare settings. And the challenge was to reduce levels of violence and aggression towards staff in accident and emergency departments, or A&E, and also to improve the patient and staff experience. So we had quite a challenge set for us. We had a very intangible problem that needed a very tangible solution. And when we began, we didn't know what that solution was going to be. So to really take it from problem to develop a solution, we had to use a design process. But what is this mysterious design process, you ask? Well, we will tell you, but first we want you to think about it and try to see if you can understand the design process. So working in groups at your tables, we're going to give you a set of cards. So the first cards are going to be the 4 key stages of the design process. So we want you to put those in the appropriate order that you think, and then we're going to give you a second set, which will be tools that we use throughout each stage of the process. Does everyone have an idea of what they think it is, or do people need a few more minutes? Good, okay. Would one team like to share what they think the order of the 4 key stages are? Any volunteers? You two look like good candidates. Go ahead. Okay, very good. All right, would anyone like to tell us what tools they think we used in the discover stage? Yeah? Very good. All right, now we're not going to give you the answers right away. So you will have to be paying attention all afternoon. But we're going to explain how the process actually works.
This is what we call the double diamond process. So this process is divergent and convergent and happens twice. So we do have two diamonds. So the first diamond examines the numerous ways of looking at a problem and resolving them into a brief. The second starts with numerous solutions to a brief that are then sifted out and into a final design. As we said, the discover phase is the first one on the process. So research was a key part of this phase in order to provide the design team with a useful grounding on the issues faced by the A&E department. So the main objectives of this phase is about identifying the problem, opportunity, or needs to be addressed through design. It's defining a solution space and building a rich knowledge resource with inspiration and insights. So we used a few tools, as we asked you. So we utilized, through this phase of the process, mainly observation tools, so both observing users and staff at the A&E, doing workshops with ethnographic researchers and staff, and finally staff interviews. So this was the tools we used for the first phase, discover phase. So violence and aggression in A&E departments has been an ongoing issue for several years. So there have been several attempts already to address the issue, which typically concentrated on measures that responded to aggressive behavior, but once it already has been started. So actually, in the past, these measures has been mainly about building barriers between the patients and the staff, and it have unfortunately and unintentionally exacerbated the problem and have failed to produce a solution that reduced the levels of violence and aggression, or even not improved the patient experience. So based on that, the Department of Health and the Design Council knew that previous attempts had been unsuccessful, and that therefore they wanted to use design to solve the problem. So in order to do that, they needed to understand the problem better and carried out research in order to better understand the nature of the problem and why it was occurring. All NHS staff should expect safe working conditions free from harassment or violence. However, the reality for most of the NHS staff is dealing with aggression and violence every day. So every year, it's more than 55,000 physical assaults that are reported by NHS staff across the UK. This means actually that more than 1 in 10 staff experience violence from both patients or their family every year. According to the National Audit Office, violence and aggression toward hospital staff cost the NHS in exceed of £69 million per year, due to high staff turnover, absenteeism, and also the need to employ specialist security guards. The financial implications of acts of violence and aggression are particularly prevalent in emergency departments, where patients are often in pain and emotionally distressed. To better understand the issue and its implications on NHS staff, the Department of Health asked the Design Council to look into the different causes of violence and aggression in A&E departments. Over 300 hours of ethnographic research actually revealed a commonality between many of the issues experienced by NHS trusts and identify what we called perpetrator characteristics and common triggers of violence and aggressions. So these are the perpetrator characteristic that has been defined as persons. So we can see clinically confused, intoxicated, distressed or frightened, frustrated, and antisocial or angry. So these characteristics are common to individuals who may be more likely to commit high-level acts of aggression or violence. But beyond the individual characteristic, research documented a number of escalator or triggers of violence and aggression. So these triggers are defined as clash of people, lack of progression, perceived inefficiency, unsafe and inhospitable environments, intense emotions, inconsistent response, and also staff fatigue. So while these triggers are noted separately, they are typically experienced in tandem and affect almost any type of visitors. These triggers often lead to an endemic culture of low-level acts of aggression. So we can say this behavior is largely unreported, but equally, if not more, damaging or corroding the staff welfare and their ability to deliver high-quality healthcare. Violence and aggression in A&E is the culmination of many factors. The environment is unfamiliar and uncomfortable for many visitors. Most visitors to A&E are commonly in pain, as we said, need relief, and just want to leave this department as quickly as possible. So due to the very different needs and characteristics of visitors in a confined place, coupled with the common triggers of violence and aggression we talked about, people's emotional states are delicate and therefore have a much lower tolerance threshold. It is this lowered threshold, as well as their injury or illness, that often causes people to act in ways they may not normally act. Incidents of violence and aggression are often the consequence of a patient or visitor's accumulated frustration due to a very poor experience. So as mentioned, there are a few range of violent and aggression acts that can occur in an A&E department. The low-level acts are commonly unreported because actually staff tend to attend and to expect hostility and inappropriate language from the patients. Severity of violence and aggression increases from verbal abuse to severe physical violence, while these highly physical acts of physical assaults against staff are detrimental. They are much less common and often the result of external factors compared to low-level acts of aggression.
So after compiling all this research, the Design Council and Department of Health needed to pose a brief to designers to solve this issue. And to do that, they compiled an expert reference group to help them sift through all this information and really focus in on what the key factors were and how these could then better the A&E experience. So this expert reference group included many NHS staff, such as frontline clinicians, consultants, and also security managers. But they also worked with external disciplines. So they had police and prison staff come in, who often deal with very similar issues, as well as patients and other designers. And with this group, they then took all this information and distilled it into 6 key points that then formed the brief. The first of those is a user-centered process. So it was really looking at how to better meet the needs of patients and service users from start to finish. Versatile spaces. So how could the A&E environment help better cope with the unpredictable workload and the very diverse client group that comes in? A good weight. This was very important to address patients' non-clinical needs as well as their clinical needs. Perceptions of A&E, so using communication and design to help reinforce a more positive environment and shift away from the more negative perception of A&E. Making safe, so how could design be used to minimize both perceived and actual vulnerability and risk throughout the department for staff as well as patients? And place and process clarity, how could the A&E process be more transparent and have more information readily available to patients? So the brief was announced in February of 2011. It was an open call to designers, so it could be for designers from any discipline, product design, interior design, graphic design, and they also encouraged designers to work with experts from various disciplines. And then the brief, each aspect of the brief was separate, but more than one brief could be addressed in the response. So our response addressed 4 of the 6 briefs, and we really took a more holistic approach to target behavior within A&E through environments and information systems. Now, before we move into the next stage of our process, we think it's quite important for you to understand who the stakeholders were for this project. We were working with a variety of institutions as well as other designers, but also needed to know who the stakeholders were, such as from the trust, but also the patients. So we're going to give you a worksheet, and if you can work from this and add in who you think were appropriate stakeholders for this project, think quite broad, and kind of the closer to the target, that is the people who are more relevant, and then you kind of extend out from people who maybe were less relevant, but still their needs and considerations needed to be taken into account.
Okay. Any team to share with who could be involved in the process? 4 people, for example. Who do you think in the people part has been involved?
Patients.
Yeah, patients, right. So, yeah. Okay, well, that's pretty good. So we've set it up a map here so we can see. But actually, you were very good in that exercise. I think we have everything. This concludes the discover stage of the process. Through this stage, the design council had to define the problem and define a brief for designers. In order to do that, they carried out extensive research, including observations and user interview. Bless you. To better understand the problem. The phase also included a workshop to review the findings and create a brief that could be shared with designers. So after the discover phase, we go to the define phase. So upon winning the pitch, we then had to understand the issue by using the existing research in order to define the opportunity areas for the design solutions. So the main objectives on this define phase were to analyze the outputs of the discover phase, synthesize the finding into a reduced number of opportunities, and define a clear brief by sign-off by all stakeholders. The tool we used on this define phase were basically user interviews, this customer journey, and character mapping. So we're going to go through that a little bit more deeply so you can understand these tools.
So this is the phase where we as designers really got involved. In order for us to really begin working on the project, we needed to define our team. So we worked with a consortium of specialists from multidisciplinary fields, including the psychological field, design, and research. So we worked with some service designers as well as medical designers. And we also worked very closely with 3 partner NHS trusts. So these trusts are throughout the UK, but they provided very invaluable guidance and research for us to understand and make sure that the designs were really addressing the right issues and how feasible they would be. And throughout the entire process, the Design Council really helped guide us and ensure that all milestones were met. Although the Design Council had conducted very extensive research, it was really important for us as designers to conduct our own research and witness acts of violence and aggression as they occurred. This fieldwork and research offered more insights into the user as well as the staff perspective, and also to get a better understanding of A&E environments and the processes. One of the first things that we noticed was that patients and other service users lack information about the system, and therefore they feel that the system really works against them. This negative association with A&E is precisely why it's such a bad environment, and one of the reasons why visitors don't feel comfortable, and attributes to their poor experience and the perceived negative culture within the system. But to better understand why patients were so unsatisfied with their A&E experience, we conducted an online patient survey with over 117 people reporting on their experiences at over 58 trusts throughout the UK. And this data is analyzed here in more detail, but it really backed up our own experiences and revealed a few insights. So it provided clear indications as to how patients and users perceive their A&E experience. Most of the comments were related to the waiting experience, understanding the process, and dealings with staff. So this provided clear evidence that our themes were really addressing the correct issues. And the key takeaways that we learned from this was that most patients, they rated their clinical care as good or exceptional, but less than half noted that their non-clinical side of care was very poor. A third of people didn't understand the process for being treated, and 2/3 did not always know what was happening to them when they were in A&E. And most people expected to wait for their treatment. That's kind of a universal thing, I believe, but 2/3 expected their wait to be much shorter than it was, and over half had no idea why they were even waiting most of the time. And a quarter of people felt like they couldn't talk to staff and also didn't even know what type of staff member that they were talking to. So this is obviously very problematic considering you spend quite a lot of time in A&E and are getting treated for something relatively serious, but you actually have no idea where you are and who you're talking to. So based on that, we used this research and distilled it into 4 key themes. So this led us to taking a more holistic approach to tackle the issue of violence and aggression in A&E departments. So we decided as a team to focus on the more common non-physical acts of violence and aggression. So we worked to develop solutions that would deliver a better overall experience to visitors and hopefully eliminate some of the common precursors to acts of violence. So upon reviewing the briefs, we focused on 4 overarching themes, the first of which was the arrival experience. So it was really how to create a positive first impression to visitors and hopefully maintain that positive impression as they progress through the department. The waiting experience, as we determined, is quite long, and therefore we needed to manage people's expectations, but ensure that the designs intervened before their frustrations and this lack of knowledge really accumulated. We also needed to look at how could we guide patients throughout the department and provide them with information that would hopefully alleviate some of the stress of the unknown. And looking at people, so really focusing on staff and the relationship between them and their patients and how they could feel supported within the A&E system as well. So after identifying these themes, we investigated them in more detail to understand how they currently work in A&E departments, which enabled us to identify every opportunity and how to progress with our solutions to make sure that they were as effective as they could possibly be. So to begin with, we really looked at the typical arrival experience into A&E, and factors such as finding a place to park, knowing who to speak to, where to check in, where they needed to go. All these things can really negatively affect a patient as they arrive, and this is before they've even entered A&E and their whole journey has really begun. And not to mention the stress of an accident or the injury that they're currently suffering and their slightly disturbed emotional state within the department. And we were also looking at the waiting experience. So after spending time in A&E, we realized that the process is far more complex than anyone realizes, and particularly patients. When patients arrive, they really expect to come in, get checked in, speak to someone, possibly wait for a bit, get treated quite quickly, and in one step, and then leave. But the reality of the process is actually far more complex. That it's really a series of stages punctuated by waiting. But the way patients perceive this is far different than the reality. Yes. So because of the protracted process and the number of stages, patients really don't perceive the process as it exists. The time with staff is very interspersed and generally quite quick, and the waiting periods are often quite protracted. So that means patients perceive their time in A&E as one long wait. They also, because of this, they also don't know where they are in the overall system. They just feel like they've been waiting for hours, and they really don't necessarily know how far they've advanced, or that, and why they are waiting, and that it is for a purpose. So after looking at what how patients perceive it, we really wanted to look at what is the ideal experience in A&E for patients. So I was looking at each of these stages and various elements within that could hopefully improve their experience. Some things are quite simple about just knowing where they are in the process, some things that we could and could not implement. But it was really looking and breaking down each of these elements just to have a more comprehensive overview of what most patients, even ourselves, would desire in their time in A&E. So once we understood that, we looked at these in depth, and we wanted to really create a positive interaction between staff and patients at each stage of the process. So it was really looking at how we could rehumanize A&E and prevent aggression from occurring. So the concept of preventing aggression was crucial for the designs going forwards. Rather than addressing the less frequent cases of actual assault or violence, we sought to reduce overall levels of aggression. By reducing this culture of behavior, we felt that it would help both visitors' experience of the service and staff's ability to deliver a good service. And as you'll recall, based on the research, it highlighted the frequency of non-physical aggression, and so we acknowledged that this was the precursor to violence, and as frustrations build, it was better to prevent frustrations from building, which would then turn into violence, and as opposed to the previous attempts, which were more about intervening once these acts of violence and aggression were already in motion. And so that we felt this would really maximize the potential of the designs to affect anyone visiting A&E, as opposed to just focusing on who these specific, either more violent or the perpetrators would be who are coming in the door, and that it would be something that would be more beneficial to everyone and would also help with the complementary approaches by keeping more policing or security staff in place, because we felt that really could never be removed, but hopefully mitigated. So from there, we really had to understand what guidance could be provided to patients and what information would be helpful for them. So we thought it was quite important that patients know how to find things once they're in the department, but also having instructions and information relating to their stage of care and where they are in the overall system. And in addition to providing support for patients, we needed to consider the staff perspective and how they could be better supported carrying out their daily tasks in such a busy environment, and how we can make the workplace safer for them. So we introduced measures to better support staff in the workplace, so hopefully this would create a better environment for them and help them deliver a better service to their patients. And we also looked at that in depth. So what information would staff need? So things such as inductions and more information about who the perpetrators were and what sort of actions they could take to hopefully prevent these incidents from occurring, but also feeling supported if and when these incidents do occur, that they could talk about it and report it, and that they didn't feel like they needed to accept this type of behavior, because by talking to staff, we realized most of them expect, when they work in an emergency department, it's something they've come to expect, that they should be talked back to, and that physical acts of aggression are something that just inevitably occur. And obviously that's not a good work environment, and also is very detrimental to them on a personal level, but also to the level of care that they can provide. Because these perpetrators exist, we really needed to get into the mindset of how and why they would commit these acts of violence and aggression. And so to do that, we employed a tool called character mapping. So we really tried to get into the mindset of who these perpetrators were, but looking at their circumstances and what would bring them to A&E, and what their injury or illness might be, and how they might behave within the department. To get into this, we did every persona, and we even threw in one unnecessary perpetrator. Yeah, this just gives you an idea of thinking about how broad the patients are in an A&E department, that it can be anyone and everyone. It is slightly stereotyping or profiling, but it's also looking at understanding their situation in life and how an unfamiliar environment can affect someone with some sort of mental state or disability.
Okay, so as we come to the end of the second stage, the define stage, we've now completed our own fieldwork and research to familiarize ourselves with the A&E environment and process. So in the define stage, we needed to carry out our own research in order to understand the A&E service as it currently existed. It was important to us to get a comprehensive understanding of the process for patients, who the potential perpetrators were, and also the staff perspectives. And our research provided us with a good foundation to begin the design work. So the next stage on the double diamond process is the develop phase. We took the refined intent distilled from the various research, both from the Design Council and our own research, and use it as a basis to create a set of design solutions. So the main objectives on this develop phase, developing the initial brief into both a product or a service for implementation, design service components in detail and as part of a holistic experience, and iteratively test concepts with end users. So now we're ready to begin really designing. So as we move on to the next stage, we had to understand what the designs needed to be achieved. The requirements stated the design needed to be easily implementable, non-trust specific, retrofitable, flexible, affordable, and effective. So this stage is where the design really begins to happen. In these images, you can see that the beginnings of our design process. We had to visualize our research and sift through all the information to see what has the most potential to move the design forward. So as a start, we really focused on the ideal patient experience. We were looking at different aspects of the patient journey and what elements could be introduced to provide patients with a better overall experience. So this was to really understand how complicated the system can seem to anyone who has a lower threshold in the A&E environment. We realized that more information and transparency about the patient journey would be beneficial to every service users. So this discovery encouraged us to focus on how information could be delivered to the patient and how it could be better communicated to users and what ways we could do that, we could show that. So therefore, we needed to break down the patient journey into key stages and a description of what happens at every stage.
So whilst we did this mapping of the patient journey, it became very clear that this would be useful information for everyone visiting A&E departments. So our design focus really shifted into making this as clear as possible and to have a strong graphic impact that would become the foundation of our design solutions. So over the next few slides, we're going to show you how we broke down the patient journey and the many iterations that we went through of this. So as you can see here, we really were looking at how to readdress perceptions around waiting in A&E. So it was important to illustrate the wait as being a part of the patient journey throughout their treatment. It was also important for us to show how patients who arrived by walking in followed the exact same process as those who arrived by ambulance. And we experimented with colors and icons and layouts to understand what was easier to read and how to be clearly understood from a very quick glance. So in this version, we really simplified the layout and played with various shades of the same color to make the hierarchy stand out, but also not be too in your face. And it was quite important for us, for patients, to know what staff member they would be talking to at each stage. So we started developing icons for each of the stages. And we used user testing to help inform and develop these so that they were easy to read and understand, but also communicated the right message. So this version of the process map is very close to our final version. Here you can see that we streamlined the 4 stages. We added more hierarchy, something that could be read from a distance, but we also thought it would be useful to have a bit more information about the various treatment areas and have some text on there. And to ensure that this information was communicated throughout the department, we wanted to visualize how it could be installed throughout the department as a whole, not just in the arrival area. And as you can see, we have different information points represented by these blue cubes, and we wanted to make these the recognized information point for patients as they progress through the department. And we wanted these to be various shapes and sizes, but also have appropriate information at that stage of care. So we began looking at that in detail as to how these could be treated in different areas of the hospital, such as in the waiting room, having the process map quite large and to catch people's attention, but also having it interspersed throughout the department and catching people's attention, but still having adequate information. We were also looking at the full scope of this, so how would these signs be implemented outside the hospital, in reception, and also in the treatment areas, as well as in staff areas, and could this information be mobile as well? Could it be something that patients could take with them? So because of that, we thought it'd be quite important to develop a patient leaflet. So this leaflet has the 4 key stages on it and information about what to expect in each stage. So this is something that could be handed to patients when they check in, and they could take it with them as they progress through the department so that they could refer back to it at any point. Developing a solution for patients was only half of our problem. We also needed to develop solutions that focused on the staff perspective. And to do that, we looked at a process that used reflection, learning, and reporting for these incidents of violence and aggression so that staff could recover from this, but also learn from these incidents and understand maybe what measures they could take that could hopefully mitigate these incidents from occurring. As we were doing this, we realized staff actually didn't have very much information about who these perpetrators were. And by recognizing these profiles, they could, and warning signs of the perpetrators, we thought it would be quite useful for staff to have, and how they could deal with these patients. And through that, we created cards and information regarding these perpetrators and actions that they could take that could better deal with these personalities and issues that would help keep them calm. And we also developed a staff handbook that offers guidance and suggestions on how to better deal with their patients and would hopefully alleviate any unnecessary incidents from occurring. And it was more about giving staff adequate information when they arrive at the hospital and go through training, rather than having an incident happen and not sure what the appropriate protocols were. And since acts of violence and aggression were still very likely to occur, we knew it was important for staff to realize that they shouldn't expect this kind of treatment in their workplace, and that it was perfectly acceptable to note and report when these incidents occurred. But it was also important for them to realize that they're not the only ones affected by such incidents. So it was also how to have a non-judgmental environment where they could discuss these incidents and deal with them in a proactive manner. And we wanted staff to achieve a better understanding of when, where, and from who these incidents were occurring. So we developed a staff incident tally board so people could note these incidents and look at various factors such as day or night or male and female, so they could have a better understanding as to, I guess, to focus in on maybe where the problem areas were or who they were, and just to have more insight into it. So this concludes our develop stage. So we've really developed our solutions, and our ideas have taken shape and gone through numerous iterations. And now we're ready to finalize our designs, which brings us to the deliver stage. So in this stage, we needed to take the product or service to launch. We also needed to ensure customer feedback and that mechanisms were in place, and share lessons from our development process back to the organization, so back to the Department of Health, the Design Council, as well as the partner trusts. So this stage is ongoing as we are still implementing the designs in various hospitals and currently refining our solutions as necessary. Some of the tools we used were implementation. So this was the implementation of our final design solutions. We also evaluated our solutions, and distributed the conclusions. So as we transitioned from developing our solutions into delivering a final design, we needed to refine what we were actually offering to trusts. And the final result was a 3-pronged set of design solutions focusing on the very different needs of patients and staff. So the solutions are the guidance solution and people solution, which are available for purchase and implementation at any trust. And we also developed a Toolkit, which is a free online resource for trusts or any healthcare providers. The guidance solution is a communication package that provides key information to patients and visitors as they progress through the department. It addresses many of the associated frustrations and anxieties previously identified as triggers of violence and aggression. It comprises a range of static and dynamic information as well as fixed and mobile. So we have a process map, panels, and a patient leaflet, as well as live, up-to-date digital information. As you'll recall from the develop stage, we were focusing on the key stages of the patient journey. So the final 4 stages that we got to were check-in, assessment, treatment, and outcome. These are the final icons that we used. They were found to be quite simple and easy to understand, and we also thought yellow was quite a good color to catch people's attention. So these icons are placed large scale on the process map, and the process map underpins the guidance solution. So it is displayed large scale in waiting areas, so it should be one of the first things patients see upon arriving in A&E. And it displays the patient journey as a series of stages with stops along the way, including waiting. In addition to the process map, we have a series of panels. These correspond to, these are installed in every room, waiting area, or corridor where a patient finds themselves. And they ensure that patients always know where they are in the process and have the most important information readily available to them, such as where they are, who should be treating them, why they might be waiting, and what to expect in that stage. And you can also see in the bottom, we have the 4 icons from the process map, small scale with the current stage highlighted in yellow. So this is for patients to always know where they are in the overall process. So the panels correspond to the various stages of care as outlined on the process map. And they contain relevant information to the patient at that stage of care. So from check-in to assessment, all the way to tests and treatments. So panels are the recognized information point for patients throughout the department, and they're customizable, so they accurately reflect the process of each trust. So when we implement it, we give these to the department, we refine the text and make sure it has anything and everything that they feel like they need to stay at that stage, because although the general process is the same, it obviously is very different from trust to trust. We chose a graphic style that was intentionally unhospital-like, something that was quite friendly and could catch people's attention, but also the colors were chosen so that they provided the right contrast and were in compliance with the Disability Discrimination Act, so that people who have some sort of visual impairment could easily read them. The second strand of the solutions works with frontline A&E staff through a reflective program called the People Solution. So it provides a forum for staff to consider without blame the factors that influence their interactions with frustrated, aggressive, and sometimes violent patients. So the program encourages a group of A&E staff members representing a cross-section of the department. So receptionists to nurses to consultants to meet regularly and discuss the factors that undermine the staff and their capacity to care for patients. The goal of it is to identify factors that impact on the collective mood and to work to remove the root causes of these incidents. Staff are asked to observe potential threats and behaviors and the causes of violence. But the reason for this is for them to learn from this and also to make changes that could hopefully better attend to patients' human needs, which are often forgotten because staff are they're very busy. They see hundreds of patients a day, and their mindset is generally to treat patients as quickly and as efficiently as possible, when oftentimes, although patients want to be seen as quickly as possible, they would much prefer someone who is considerate and really empathetic with their situation rather than just getting them out the door as quickly as possible. And it also includes a discussion forum for staff so that they can reflect upon their experiences and the day-to-day problems of working in such a busy environment. So the third strand of our solutions is the Toolkit. So this provides free high-level design recommendations to inspire or encourage healthcare providers to make some quite simple changes to the environments to make them a bit more comfortable for patients. And this was developed from our research where we were looking at healthcare providers and people who had implemented changes that improved the care environment. And we compiled these recommendations and broke it down into the key areas of the patient journey. And these were all in practice at other NHS trusts. So they aren't necessarily solutions in themselves, but specifications or service changes that trusts can make as and when they have money or feel encouraged to do so. It's intended to be used by NHS staff, but also architects or interior designers, people who are designing a new healthcare facility. But since this is available online as a resource, we decided to really focus on the people and the guidance solution. So in 2012, they were installed and piloted at 2 hospitals in England, Southampton General Hospital in Southampton and St. George's Hospital in London. So we worked closely with these trusts throughout the implementation process and to customize our designs. So we still have a lot to cover under implementation and delivery, but I think we're going to stop here today and just give you a quick little recap of everything. And tomorrow we will pick up so you can see the solutions installed at trusts and where we've gotten to, as well as the evaluation process and how we undertook that.
We have now completed our double diamond process. So we've demonstrated that it is an iterative process that begins with identifying the problem and carrying out the necessary research. So this exploration at the beginning of the process then converge at the end of the design phase when the objectives need to be really clear. The design process begins actually during the develop phase, which diverges again into an iterative process that requires the design to be tested again and again and refined before the implementations. So we then have to work to synthesize all of these informations and feedback we had, explorations, interviews, into a final result that could be then shared with everyone.
How did we start with prototyping? How did we show this? And how did we do our user testing? So prototyping really began just sketching on paper. It's a lot of Post-its generally. So it was really writing out the entire patient journey, and then it was translating that from something quite physical into something digital on the computer. So the very first stages of the process map, that was really the beginning of our prototyping. And it's a lot of doing that on the computer, printing it out, having a look, marking on it, redoing it. It's an interesting relationship between the computer and printing it out. Oftentimes on screen it looks fine, then you print it out and look at it from a distance and you immediately realize stuff that is quite difficult to read, or maybe what doesn't work once it's actually physical. And then user testing was very informal. We printed out sheets of A4 paper and took it out on the streets. We had developed a little questionnaire and just asked people to look at our process map and say, does this make sense? What do you think this icon means? Do you understand this? And just getting feedback in that way. It happens quite quickly. In a day, sometimes you might have, if you have 2 or 3 different people working on it, it's coming together and then revising, and then from there moving forward. Sometimes you have something to really focus on that you then work on for a week, and it's just minor tweaks. Unfortunately, it happens so fast and so quickly. Images are kind of hard to, it's very hard to visualize that for people, but you could see from the very beginning slide much of our studio, which just has stuff pinned up everywhere. And it's a lot of mocking up and looking at that and getting feedback from everyone.
So I guess that's it. So thank you for listening, and I guess see you all tomorrow.